Welcome to part 2 of our APCCC Highlights podcast. The APCCC is a biannual meeting that takes place in beautiful Lugano. It's attended by an invited panel of experts from all around the world who gather together to talk about the most contentious topics in advanced prostate cancer, and also by very many delegates who enjoy a quite stunning array of state-of-the-art plenary lectures. And of course, the panel do vote on some of the most contentious areas in prostate cancer to help give some guidance for clinical scenarios that are outside current clinical guidelines. Myself and Renu caught up with a bunch of faculty and participants in the first podcast, and we've got more great highlights coming in this podcast. Thanks again to our goal partners, Bayer China, who support these conference highlights. There was a bonus episode that we dropped during the APCCC, which was a bunch of fun. We got to catch up with some other well-known podcasters in the world of urology and GU oncology. We had great fun with Tom Powells and Brian Rinne from the Euromigos, and also with Gill Morgan from OncoAlert. You'll find a link in the show notes and here on the screen in front of you. Enjoy.
So we're here with Dr. Elena Castro from Madrid, medical oncologist extraordinaire. Welcome, Elena. Friend of the podcast.
Hi, thank you for having me.
Now, Elena, are you enjoying the meeting so far?
Of course, it's very nice to listen to the colleagues' opinions and the discussion around some very hot topics.
Absolutely, and you've had a busy time because you were at EAU in Paris just recently, and then now you've come over to Lugano, and you're looking stunning. You're about to do your talk, right?
Yes, I'm about to do my talk.
And you're going to be talking about PARP inhibitors in prostate cancer, and this is a contentious issue. It's becoming more and more topical.
And here at this session, it gets a half a session or almost a full session to itself. But a simple question I have for you is for the urologist who doesn't spend that much time looking after MCRPC. Have you guys and girls figured out which patients benefit from PARP inhibitors? Do you have to have only a BRCA2 defect, or BRCA2, BRCA1 ATM, or kind of just unselected? What's the current situation?
I think the benefit for patients with BRCA1 and BRCA2 and PALB2 alterations is very clear. For patients with ATM, the benefit doesn't seem to be that much as for the other patients, and we're slowly learning whether patients with less frequent alterations benefit or not from PARP inhibitor. For patients without HRR defects, it is true that some of them may benefit, but we don't really understand who those are. And the side effects are the same for everyone. So I think it's also a matter of balance between the potential benefit and the potential side effects.
And therefore, in your practice, what do you tend to do? Only selected patients with BRCA1, BRCA2, PALB?
Yes, so I tend to treat patients with BRCA1 and BRCA2 and PALB2 as soon as possible with a PARP inhibitor. For patients with ATM alterations or TEC2, I may use other systemic therapies before and then use a PARP inhibitor if I have the opportunity, because the benefit doesn't seem very great for those other patients. For patients without HRR alterations, unless it's in the context of a trial, I'm not using PARP inhibitors.
There you go. Clear messaging.
Absolutely. And Elena, at what stage and which patients do you think should be tested? Should we be looking at moving testing to earlier in localized high-risk disease, or should we wait until they develop metastatic disease? What's your opinion on that?
As of today, the reason to test is to be able to use a PARP inhibitors, and the current approvals are for MCRPC. So I think it makes sense to test all patients that with MHSPC that are being treated and the PSA starts to go up, and then we will be able to get the results before we really need to start the first-line treatment for MCRPC. If we have the opportunity, we could also test at diagnosis of MHSPC, because these HRR defects are early events already present in the primary tissue, so it's something we can do. Do we need to test all patients with localized disease? Well, this will provide us with some information, but there may be some patients that it will take years, or some years will elapse until they are in the situation to be offered a PARP inhibitor. So I think at least all patients with metastatic disease must be tested. The others, if you have chance, that is okay. But the meta study, we should make sure that they are tested.
And your talk specifically is on managing the toxicity of PARP inhibitors. Can you tell us a little bit about how well these drugs are tolerated? What is their monitoring like? And what are the toxicities that you commonly see?
So the most frequent toxicities are hematological toxicities, particularly anemia. And in the trials, grade 3 anemia was reported in a third of patients. So these are patients that need careful monitoring. These side effects are more frequent in the first 3-4 months. So during those early months, we need to make sure to see the patients at least every month or every 2 weeks and offer supportive treatment, blood transfusions, etc., if needed. Then we continue to monitor the patients regularly. And there's also this concern about late toxicity in the form of myelodysplastic syndrome or acute leukemias, which are very rare, but it still is something that may happen, and particularly with very long-term treatments that we are starting to consider in the trials for MHSPC, etc. So we need to see what happens. We are learning from the ovarian cancer treatments, and I think we need to further understand this.
And like all these treatments in prostate cancer, Elena, they're moving forward and forward and forward. And we currently have a neoadjuvant study open at Peter Mac. Our colleague Arun Azad is a global PI, I think, on a novel PARP inhibitor. And clearly, if we've got patients that we're planning to do surgery on, we can't have them getting anemic and having a risk of myelodysplastic syndrome. But these novel PARP inhibitors that we're using certainly in this neoadjuvant study don't seem to have the issue with anemia. So PARP inhibitors themselves are evolving. We are going to see a generation of PARP inhibitors coming that probably will have better tolerability.
Absolutely. So the new PARP the PARP inhibitors we currently have inhibit both PARP1 and PARP2, and PARP2 seems to be involved in the erythropoiesis. So if we are able to inhibit only PARP1 selectively and no PARP2, we may see less hematological toxicity, and this will allow better combinations, neoadjuvant use prior to surgery, etc., etc. So, yes.
And as we move it earlier in the spectrum of the disease, tell us a little bit about the synergistic effects between PARP inhibition and AR-targeted therapies, or even PARP inhibition and radioligand therapies like lutetium PSMA.
So the synergistic effect with AR inhibitors has been explored in preclinical studies, and perhaps we don't understand this very well. There is a crosstalk between the homologous recombination repair pathway and the androgen receptor pathway, and they seem to modulate each other. And although we don't understand well this mechanism, it's true that in clinical trials we've seen that the addition or the concomitant treatment with these therapies results in improved rPFS compared to the treatment with either agent. So there must be some kind of synergistic effect even when we don't understand it well. But the long-term outcomes don't really seem to be as interesting. The combination with immune therapy didn't work, and other combinations we are still waiting for the result. With lutetium, I think it's also very interesting because what we do with lutetium is we damage the DNA, and with the PARP inhibitors, we prevent the cells from repairing it. Yeah. So it is very, I think,
theoretically it should work.
Very, very interesting. Absolutely, we need to see the results of those trials.
Yeah, because we've got the LoopUp trial going at the moment. That's looking at olaparib and lutetium PSMA. So I think it'll be really interesting to see what happens in this space in the future. Elena, it's such a pleasure to have you on the podcast.
And good luck with your talk.
Thank you. Thank you for having me.
So we've tracked down a friend of the podcast, Professor Nick James from the Royal Marsden. Nick, how are you?
I'm very good, yeah. Nice
good,
to see you.
Good to see you at the APCCC.
Yes, indeed. Yeah, lovely to see everyone here. It's just a
big meeting this year, isn't it?
Yeah.
So first morning we've had really big sessions on high-risk localized prostate cancer, both the upfront treatment and then in the recurrent setting. Lots of ongoing discussions again about optimal treatment for these patients.
Yes.
One of the big discussions was around the very high-risk patient, the so-called stampede high-risk patients, these men who have, high PSAs, high Gleasons, etc., etc.
Yes.
With the addition of abiraterone to ADT and radiotherapy, some of the questions were, for example, can you swap out Abi and put something else in, like another AR pathway inhibitor?
And of course, the correct answer to that is we don't know. But I guess the practical answer is, in most settings, these drugs behave very similarly, even though they clearly have a distinct mechanism of action. The end target appears to be sufficiently similar that I think it's reasonable to extract. We will find out. There are trials like Atlas with apalutamide, RAD with enzalutamide that will answer those questions, but they're taking a long time to report. I assume because event rates are low, but I don't know.
Yeah, exactly right. And the other question was about stopping both the ADT and the ABI. If these patients are doing really well, the PSA has been wiped out, and I suppose you don't have trial answers to this yet, but you have clinical practice answers. Do you stop in these men?
Well,
everything?
When we designed Stampede, Abby, we were very concerned about over-treatment, so we picked a number, 2 years. I mean, God knows if it's the right number. But we did make the point that we wanted people to stop. And we've done some subsequent stuff. We've published quite a lot of recent things from Stampede by hooking the long-term survival data up to the NHS digital records. And what we see, if you pick cardiovascular disease, for example, is that being on Abi at all, or any of the other drugs as well, we kind of associate Abi with cardiotoxicity, but they're all cardiotoxic. It doubles your cardiovascular risks, and Stampede has deliberately got a very low cardiovascular risk loading because we wanted people to be at risk of death from prostate cancer and not death from intercurrent causes. So if we're seeing it there, you'll see it more elsewhere. And one of our research fellows just did this excellent meta-analysis looking at the cardiovascular impact of AR targeting drugs and its effect on survival. And if you look at 0 versus 1 versus 2 cardiovascular risk factors, you've got big decrements in the survival curves. So I think we have to be very mindful that there's more to a man than his prostate. And if you're looking at very long survivals, as we are in this group, you have to be really mindful to not kill people.
And you can always come back again. We can do other things.
Exactly.
And it's been a busy time for you, Nick, because EAU and now here, and with all this interest and attention on the Lancet Commission, and there's a dedicated session here at APCC on that.
Yes.
It must have been crazy for you.
It is, and I was in Brazil last week. We did a Brazil launch of the Lancet Commission in Portuguese last week.
Wow.
So which was good. So the Lancet Commission has been an absolute revelation for me. I've learned so much, and the most striking so we did a couple of things. We looked at where cases were going to go, and then kind of everything followed from that, and Declan was involved in it. And the most striking thing is that cases are at least going to double, and almost all of the doubling is going to be in places where we think of prostate cancer as being not that common, so Asia, Africa and so on, but actually it is already quite common, but it's going to get much more common. South America as well, which is why I was so keen to do the LATAM launch. It's going to double in Brazil and places like this, simply because people are living longer and they've got relatively young, compared to Europe, age structures. So there will simply be more 60-year-olds, 70-year-olds in 10 years' time than there are now. And that rate of change is going to be so fast that you can't deal with it by just training more of us, more oncologists, urologists. We're going to have to set up smarter diagnostic systems that don't depend on having lots of doctors and stuff, and hook them up to treatment systems. And you for sure are going to need more surgeons and oncologists, but you don't need to be doing the biopsies and stuff. You need to be doing the surgery and things like that. So it's been quite a really interesting piece of work, I think, and quite shocking in terms of the implications.
Eye-opening, really.
And it's not like a normal paper. These Lancet commissions do tend to attract the eye of policymakers and others. They have a lot of respect, I think, within health departments and so on. Have you sensed that? Have you sensed some reaction?
Oh, well, very much so. I mean, you yourself mentioned that one of your Irish colleagues had been asked by the Irish Minister of Health. We've had a whole series of questions in Parliament in the UK about the Lancet Commission and its implications. We've been in the process of, I hope, setting up a pilot project in Lagos around early diagnosis, hooked up to one of my classmates who just coincidentally happened to be the public health director for Lagos, 30 million people. So he, of course, knew all about the problem, but we don't just look at say what the problem is, we're proposing solutions. So we're in a position that we can road test some solutions there, which I'm really excited about.
Good luck.
The other exciting thing on the horizon for you, Nick, is obviously the launch of your new podcast.
Yeah.
So congratulations. Congratulations.
You're a podcaster now, not a friend of a podcast.
Yeah.
And as all podcasts kind of emerge, you found a niche, an area of need.
Yeah.
Well, I hope so, yeah. I mean, there's a lot of podcasts, excellent podcasts like this, looking at the latest developments. So, and I have to credit my wife with this. So she said, well, nobody knows, or almost nobody knows what it's like to set up a trial, just how hard it is. Why don't you do a podcast about that? So we are. So we've just done episode 1, and where, for example, we mentioned that issues we had with the MHRA last year, the UK regulator, who sat on our application for 6 months after we got ethics approval without looking at it, simply because they didn't have enough, post-Brexit, they haven't got enough regulators.
Wow.
And just things like this, and access to routine data we're going to deal with in episode 2. So we want to just download routine data rather than collect it, where it's already been collected by the NHS.
Yeah.
The bureaucratic nightmare around this is unbelievable.
But maybe if you talk about it, it'll start changing a little bit as well, because I'm sure you're right, sharing your wounds of setting up things like Stampede over the years, others will learn from the blood you've sweated over these trials.
Absolutely. I mean, just to give you an example of absolute unbelievable Alice in Wonderland world. So we applied to NHS England for access to routine data for one of our bladder cancer trials, and they said, well, you can have the data, that's fine, it's a fee. Not that much for a one-off drop. And then they said, but it depends on whether you're going to manipulate the data or derive it. And if you manipulate the data, you have to delete it when you finish doing the analysis. Well, that doesn't really work. We can't delete half the data in our database. And so, but if we derive it, we can just keep it forever off the one-off fee. And I said, well, that's fine, we'll just derive it. So they said, but we decide whether you manipulate or derive.
Oh, no.
And you have to try and guess what is actually manipulated and derived. With no input. It's like Alice in Wonderland. It honestly is.
And what's the podcast called?
The podcast is called Trials and Tribulations.
Trials and Tribulations.
I like it.
It's on Spotify. It's on YouTube. And
there you go.
Fantastic. Everyone, check it out.
We saw you tweeting about it. We'll put it in the show notes. And
Absolutely.
Give it a play. I'm looking forward to have a listen myself.
Me too.
It'll
It's
probably
going to be good.
make me even less inclined to do trials, disappointingly.
Exactly.
But if I was a younger Declan, I'd probably think, yes, this is going to be my roadmap for how to set up my next trial.
Yeah, I don't know if it's a roadmap. I think what we're aiming to do is highlight what the issues are.
Okay.
And you do trials. It's the gestation for these things is years, isn't it? Yeah, elephants are much quicker to produce than trials.
Keep up the great work. Good luck, Nick.
Good luck, Nick.
Thank you very much.
So we're joined by panellists, Anthony Joshua and Bertrand Tombal, medical oncologist from Sydney, Australia, urologist from Belgium. Hey, good to see you.
Also
guys.
from Australia.
Yeah. Kind of. He spends a lot of time in Australia.
That's right.
Hey, look, we just had a great session there. It was the PARP inhibitor session. But there was a discussion about control arms of trials and what are the appropriate control arms. And indeed, that's one of the key questions we were asked to vote on this year. So there's the example of the metastatic CRPC patient who has been on an AR pathway inhibitor up front and is now CRPC. What do we think about switching to another AR pathway inhibitor, so-called?
And it was great because Ian Davis's talk set that up really nicely. I thought his conclusion slide was fantastic. What not to do.
And 95% of the panel said no, you shouldn't switch. You need to do something different like docetaxel or whatever it's going to be. However, we know that the control arms of a lot of the trials in this space have AR pathway switch as the control arm, and it's quite controversial. There's been a lot about it this year on our podcast. We had Vinay Prasad on a couple of months ago after ASCO GU, and he's a bit, he gets a bit fiery about this and again, slightly unprofessional attacks on people, we might say, but nonetheless, the topic of unethical control arms is up there. And then you stood up in the audience and made a comment, and you used the word unethical control arms or trials, Anthony. And so I thought we should chat to you.
You got a round of applause.
You got a round of applause.
So I'm not sure if we have time to answer this, but I was going to bring up this issue about the control arms in some of these clinical trials, which have been brought up by two speakers, and there doesn't seem to be a consensus question which has been submitted on whether these are appropriate for our patients, but I would just like to sort of get people's opinion. Silke and I have actually published on this that I consider these RP switch control arms some potentially unethical in the sense that they're not transparent, which is the problem. They're not in the title. The RP switch implications are not in the consent form, and they're not in the protocol, and they're not justified. I think it's a big problem. I think there's going to be a day of reckoning from our patients who are going to say to us, why did you allow me to go on a trial when the control arm was substandard? And the only people that are endorsing this control arm, it appears to be, are the FDA, who whose mandate is simply to find something which is vaguely applicable to the US population. It would be far better if the control arms on all these studies were physicians' choice, thereby allowing us to do the best for our patients, not the best for the FDA.
Anthony, can I take that? Can I take that?
Yes, you got a round of applause. So do you want to just expand on that a little, or tell us what you think?
Yes, sure. So I think that the reason why they're unethical is they're not transparent. So if you put it in the title, if you put it in the consent form with very specific wordage, and you put it in the protocol about why it's justified to do it, then maybe it is ethical. But none of those three things have happened, and it should especially be in the consent form to say you're being offered a randomized trial. The control arm may be not the best treatment for you, yet there may be some advantages in going on the trial. Are you still willing to go on the trial? So that important piece is missing.
So you think the control arm, the implications of the control arm need to be explained a bit better. It means if you're in the control arm, this is what you're going to get, and you're not going to be allowed to get other things that we know prolong life in this setting for you as a patient.
It has to be completely transparent. Yeah. So you could make an argument about the greater good for the greater number eventually. We're trying to get this new drug on market, and this is the way we're going to do it. But you should also put that in the consent form to say, by participating in this trial, you are potentially sacrificing your health for the good of the others into the future. So that is completely missing. And I think we have to be completely transparent in our consent forms to say why we're doing these trials and what the nature of the consent form is. And what the point I made was the best thing to do would be to say it's investigator's choice. So if you say it's investigator's choice, it's got two advantages. One, the patient gets the best treatment, and secondly, it builds on the evidence base. Because if you can't build on the evidence base, we're going to end up like breast cancer, where there are potentially too many treatment choices at each individual point, and it doesn't work for the benefit of the patient. So just given 7 different options at every treatment junction, and we don't know the best path for the patients. So it would be better for 2 reasons to have investigators' choice as a control arm in these studies.
And Anthony, you said when you got up there and asked the question, you said, there's going to be a day of reckoning when these patients ask you, why was I allowed to be put into this trial? And I think one of the issues with these consent forms that spell that out is unless you spell it out in the language that you just said, patient's not going to understand it.
Yes.
Right? So investigator's choice makes a lot of sense for that reason.
Yeah, I think it's underappreciated as a control arm. Vinay has actually written a paper on investigator's choice in oncology control arms, which is a great paper, and the listeners should read it, that sort of does make a similar point, that it's underused as a control arm. And so everyone's looking for the cheap, fast way out in their control arms of their clinical trials.
He also makes points about the role of the regulator in all this, because these trials are set up in conjunction with the FDA principally, and that's it. And they agree that. And I don't know how to make sense of all that relationship between the regulator and the trialist and the industry that will agree these substandard arms. Now, Bertrand, you and I have, you have a big interest in value, extracting value for patients to make sure they're getting best care. What are your thoughts on this whole discussion about regulators?
This is clearly, I think the regulator is changing. I mean, Johan de Bono was mentioning that he was surprised EMA approved olaparib and abiraterone in all comers, but EMA until there was not looking at value. They just look at safety and efficacy, and usually it's the company who propose a design, like you say. They propose a control and they say yes, it's okay, then they say yes, because in Europe we have a second line, which is you have to go to meet HTA bodies. NICE is the most famous, and then you start speaking about value. So basically, what is it worth for? Because value is for patient, for payer. But for patient, if you ask a patient, they want to live longer, they want to live better with limited toxicity. And then you take a trial like Propel, for instance, and you ask the 3 questions. Do they live longer? No. Do they live better? If you look at quality of life, we very, very happy with it doesn't deteriorate the quality of life. That's not what patients want. They want a better quality of life, which is different. And they use this kind of prolonging quality of life. But the bottom line is that there is no improvement in your quality of life. And the toxicity is substantial. So no surprise if you ask an independent body to look at Propel and say, what does it worth? You're going to come with a low number. If you're interested in value, I mean, the minimum you should say, because you should do it very nice, is you go on the ESMO website, and ESMO has created 10 years ago this magnitude of clinical benefit scale. So basically they rate all the drugs that have been approved by FDA or EMA, and they give them a rating from 1 to 5. You would see that, I don't know, like enzalutamide in metastatic CRPC as a 4. And in the Propel indication that as a 2, because they say, where's the value? And I think that the problem is it's not only the discussion between the regulatory body and the company, because they look at safety. And to me, that's the problem of what I call drug design trials. So keep in mind that when a company is designing a drug, they're going to do everything to maximize the visible benefit so that it looks, like a good thing. They're going to do, for instance, they're going to do the trial in country where the standard of care is low or something like this. But then it's up to us to say, okay, what is the value for our patient? And when you look at this, you're kind of shocked. Very interestingly, the only drug that was rated a 5 was Radium. Why? Because Radium increases overall survival, has minimal impact on toxicity, is very limited, and they had done quality of life study showing us. So we have to be careful and not say, okay, that's a paper in New England Journal of Medicine, so that's a good drug, so we should, no. We have to go in detail and say, what's really the value? And I think I'm happy they make Propel and Talapro, because that's the first time we have academic here who stand up and say, hey, stop here. That's madness. Let's pause, let's see what do we get for our patient here, and that's great.
Yeah, what do you think?
No, I agree. I think the FDA's only mandate is to do something which is, as I said, vaguely applicable to the US population. So that's their mandate. That's not my mandate when treating patients, and I don't think that should be the patient's idea of a good treatment, because if the FDA says it's okay, then it's okay. That's not a good reason.
No.
So the patients want to live better, live longer. That's what they want.
I think the assessment of value is different based on who is assessing it, regulatory bodies or physicians.
And a day of reckoning coming, you say, well, look, it was a really good comment. It got I think half the room clapped. But the other half
the
of the room
rest were in
trialists.
disbelief.
And
then the rest of it.
But it's a really important discussion to have, because
absolutely.
every minute that we pass by, someone else is sitting in a room designing another trial that we're going to be recruiting patients into. And I think your comments really hit home.
Once again, I think that because trials are getting more complex, we are moving more towards pragmatic trial, which is okay. You do what you do on a usual basis, but you have the possibility or not to have that new drug.
Yeah.
So then you really measure what is important is that we have an armamentarium, then we're coming with a new drug, we put it in the pathway and we see what it does to the pathway, which is much better. I mean, there is more than using enzyme, or ABI, ARPI crossover. It is much than that. It's that, okay, the studies say the control arm and standard of care. But in standard of care, you cannot give docetaxel or Radium. So it's kind of a selected standard of care. Say, hey guys, what's this? I mean, that's crazy.
Lovely. We love it.
Talk about this forever.
We can Great. Keep up the fight.
Yeah,
absolutely.
Thanks,
Thank you.
Bye-bye.
Okay, so here we are with the superstar nuclear medicine panel at APCCC in 2024. I'm starstruck, really, you guys. Too many of you to introduce all in one. But Michael Hofman, friend of the podcast, thrilled to be here at APCCC in Lugano. This is not your first time, of course. Is it as good as the previous times? Is it better? Is there more nuclear medicine this time?
Look, well, nuclear medicine's growing, so we have a growing panel. As you can see here, I think Stefano was number one.
Yes, I was like 6th edition ago, so a long time ago in St. Gallen.
Wow.
Yeah, we were still babies at the time, but he's the founder.
Amazing.
So we looked up to him.
Yeah, thanks very much. But it's been growing a lot, and you've been bringing a lot of science, the whole of you. I'm just bringing jokes and some fun and some, but the science came with you.
But I think, Michael, you did a recent tweet that said, a few years ago we would ask, would you do a PSMA PET-CT? And now a lot of these questions assume that you've already done one. So we have really come a long, long way.
There has been huge progress. So my first one was the 2019, and at that time it was all, should you do a PSMA PET? Now the questions say, we've done the PSMA PET, it shows this, what would you do? So it's really nice to see it be adopted clinically.
Now we've met Stefano, let's meet the rest of the nuclear medicine panel. We've got Ken Herrmann from Germany. Ken, welcome.
I'm very happy to be here.
Ken's number 3.
Okay, we skip number 2.
Well, number 2 was Michael.
All right.
It was Michael, yeah.
That's right. And then we have 2 new members that aren't really new. They're very well known. But
Very
I think
well
it's the
known
first
in the
time
field,
they've come
absolutely.
to this meeting. Louise Emmett and Tom Hope.
Louise from Sydney, Australia, and Tom Hope from San Francisco in the US. So great to see you guys here. Louise, what are you going to be talking about in your talk tomorrow?
I'm talking about dosing in special situations and toxicity.
Okay. Very important, because we often don't think about that when we talk about, lutetium PSMA. It's getting more and more popular. So I think dosing and toxicity is really important, especially when you're using it earlier in the prostate cancer spectrum.
It was super interesting as a question because, when I talk about dosing or dose reductions, I actually don't do that very much. So I had to really think about my question. It was quite difficult. Some of these questions are super difficult.
But I think you're in a good position to talk about it, because the NCP trial was the first trial to use adaptive dosing.
It was. First try to use adaptive dosing. That's not dose reduction, though. That's actually stopping when you don't have a target.
Right.
I have to correct you, though, because therapy was the first trial.
Oh, yeah, that's true, actually.
Yes.
I knew we'd have this problem, but...
Well, we have a bit of competition, Melbourne, Sydney.
All right, okay, yes, fair enough.
But you're right, adaptive dosing, totally. Stopping when you don't have the target, as opposed to just dose reducing for toxicity.
And Tom, patient selection for radioligand therapy is super important. What are going to be the main take-home messages from your talk?
So the main take-home messages are you should do a PSMA PET. You should
Excellent.
look at it, and then probably, unfortunately, apply the vision criteria. Keep it simple, because a lot of patients benefit from this. So trying to be whittling it down to these patients who respond really well actually prevents some patients who have lower uptake from receiving the drug.
So only do a PSMA PET CT, or always do a PSMA PET and an FDG PET?
Well, luckily Mike's not giving my talk. So if Michael were giving it, we would be saying we should all do FDG PET CTs. But because I'm going to be giving it, I will not recommend FDG PET CTs routinely in the screening of patients.
Very interesting. Now, a couple of years ago when you came to our Prostate event in Melbourne, I remember he kept getting asked, what radioisotope should you use? Or if you're doing a PSMA PET CT, should it always be gallium? And you always used to say, people, stop asking me that question. Just use whatever is available to you. Do you still believe that?
Yes. I think the world's slowly changing, right? So back at that time, it was PSMA 11 versus DCF-PYL.
Yeah.
Now in America, we have RH-PSMA 7, which does have maybe a little more liver uptake, so potentially could have an issue there. And then, in Europe, you have the issue of 1007, right? Mm-hmm. Which is a whole other thing. And maybe, Ken, if you want to talk about that, but we don't have that issue, thankfully.
This was already one of the hottest topics, actually, 2 years ago, that we back then discussed about the unspecific bone uptake. Truth is, if you have experience, I think it's a pretty good tracer. You need to know the pitfalls, and then I think the false positives should not be such a huge problem. But the big thing is, of course, it's different PSMA tracers. People get confused. And when you go to meetings, the biggest question clinicians ask us right now is really, what is the problem with the positive bone uptake? And this being said, we're going to hear a lot about Spider-Man tomorrow. And I think a person who's going to talk about unspecific bone uptake is next to me.
Yeah, true. And it's surprisingly that it's the same topic that I covered 2 years ago.
Okay.
So it's very clear that 2 years ago I was not able to provide a clear answer because they asked me
They're
again.
giving you another chance.
Yeah, so they gave me the chance to give the trolley lecture because I'm the last lecturer on the podium. So just before people leave for the train. It's not the PSMA train, it's the real one, and you don't have to miss it. But it's very true, as Ken said, there's still a lot of issue regarding false positive findings. And the point in real life is that we are all experts and we learn how to use different tracers. So to me, it's the same point of Tom. Use whatever is easier, available, I wouldn't say cheaper, but probably more easy to access. But as a matter of fact, when you spread the use in many centers which are not necessarily outstanding by the academic point of view, it could be psychological under pressure to read and prepare a report because you have a patient referred, for example, for BCR, and there's pressure from the patient. First of all, hey doctor, tell me where the lesion is, I want to be cured. Pressure from the urologist, from the radiation oncologist, give me a target, give me a target. So you say something faint, and it's capturing your attention, and you tend to over-report and overestimate. So the point to me is not about ultimate choice of the tracer, but rather the attitude. You should be careful, because over-treating and over-diagnosis is very risky, also for the reputation of the specialty and the way the trials are run and all those, worrying considerations. I'm sorry, I've anticipated all my lecture.
It sounds like we're going to have a bit of crossover in tomorrow's imaging session.
Yes, absolutely.
I'm talking about differences in radioligands. That was my topic. Are they all interchangeable? Yeah. And then we're going to deep dive on this next year because you're launching a new APCCC meeting. I think you're two other founders of APCC Diagnostics. Can you tell us a bit about this meeting? February 2025.
I'm sorry, I'm just the supporter. I'm the second because Ken will be the chair because they were in need of another figure to put in the picture, but Ken is the guy in charge.
Tell us about it.
It's of course completely untrue, but the interesting thing is that we see at this meeting, right, that PSMA imaging is going to play a more and more important role. We cannot solve all the questions we have. Actually, PSMA imaging is very interesting, but we need to talk about CT, we need to talk about MR, we need to talk about pathology, we need to talk about biomarkers. And our idea was actually to find a way to actually address this and go outside of nuclear medicine, get clinicians on board, get oncologists on board, get also radiologists on board. And we are happy enough that Silke is actually open to the idea, supporting us. We get the whole APCC label, the branding, the support, beautiful Lugano. And of course, as you know, Stefano is the most important part of the whole organization. So it's.
But I think the two meetings will be very complementary, and it takes a lot of pressure off the main meeting. There are a lot of topics to cover, and there are a lot of nuances within imaging and theranostics that you can cover in the separate meeting. Will you be including any AI?
We will, of course, include AI. We will include AI not only for imaging, but also for biomarkers and pathology. And to take advantage of the microphone, I want to say one thing is, when I compare to 2 years ago, there are two big things which have changed for me. The first thing is we have a state-of-the-art therapy lecture. Because for once we have now phase 3 studies. Not only one, but actually a couple of ones, and also a couple of ones which are IITs, therapy, and ZAPI. I think we have for the first time at the oncological level data to show and to really call it state-of-the-art. And the second thing, it's my personal biggest highlight here is that we got Pete Ost on the PSMA train.
Fantastic. Louise, the other challenge, I think, for nuclear medicine is really to standardise PSMA PET-CT reporting. Can you tell us where you're up to with efforts and what some of the challenges you face in that are?
No, totally. I think we have a problem in terms of making sure that we all report the same way. Mm-hmm. And so this is a big initiative that we've got undergoing worldwide, really, to try and put us all on the same page. So when we report for diagnosis, for staging, for biochemical recurrence and for treatment response, to educate people and also to have it so that we've got standardised reporting templates. So this is something called Spark, and we're hoping that we can really take a lot of criteria that a lot of really smart people have developed and put it all together into one package so that we can use it.
Fantastic. Future is very promising and bright.
It's a bright future in nuclear medicine, always.
Scintillating.
Scintillating. Well, I want to thank all of you for joining the podcast and giving us an update on where we are with nuclear medicine, imaging and theranostics. And we look forward to APCCC Diagnostics 2025 in February. Everyone check it out.
February 27 to 28. Lugano.
27 to 28. Still in Lugano, so you still get to come to beautiful Switzerland. Well done, all of you. And hopefully looking forward to a great session tomorrow. Okay, so it's APCCC 24 in Lugano. We're in day 2 and we're here with the two people of the hour, right, Declan? It's Dr. Silke Gillessen and Dr. Aurelius Tomlin, the conveners of this fantastic meeting. Welcome to GUcast.
Thank you very much.
Thank you for having us and thank you for supporting APCCC.
Yeah, I have to say you really make the best videos ever. But I think that was the drones.
Yeah, we've got the drone. We're going to try and fly it tomorrow unless the police shut us down. I saw a helicopter. I think it was the Euromigos arriving on their helicopter.
We had to be careful.
There are aircraft nearby, so the drone might, interfere with Tom and Brian arriving in their executive helicopter. Yeah, no, it's great to be back. Goodness me, it's day 2 of the meeting. How many delegates?
So this year we have more than 1,100 registrations. Some of them are online, virtual only, but there's more than 750 really participants really in, and I also feel in the room.
It feels
not only, yeah.
Well, it's a very unique meeting because, unlike other meetings where there are multiple plenary sessions and multiple breakout rooms, this is one big plenary session and it is jam-packed. This is the stuff to listen to, so it's really quite an incredible, very intense couple of days.
It is very intense, and what always surprises me is that all the experts, or many of the experts, are actually in the room. They are not just coming for their talk and leaving, like even Johan de Bono was sitting in the side effect session. That shows me that it is of interest, to people, that he's in drug development. I mean, he's not probably not interested in hot flushes, or I don't know. But this is very important that we have this interaction also with the panel here in the room.
Yeah, that was always like that, and I think really that also obviously then makes really good comments, really good questions. The interaction I think is quite nice. Interesting stuff. And then also they have done the trials, so they have already more information. What maybe you can't all read in the papers. So I think it was quite interesting what Neil said today, who obviously knows Emborg by heart, and it's quite interesting.
Yeah, I think it's amazing because the general feeling that I get, Declan, is that this is the ultimate consensus where, the information that you get from this meeting is what will really guide your practice. So it's very important information.
It's also eye-opening to see that we have not consensus on most of the questions.
Yeah, this classic split.
It shows that there's different practices, different interpretation, but it evolves over the years. We've seen that in many topics.
So if I may just add, what I found really interesting that really someone from a big center in the US came to me and said, I think we have to rethink our guidelines, internal guidelines for adjuvant radiotherapy. So it was quite interesting. So I think really because we tackle a lot of questions that you see in clinical practice where we don't have really hard data, I think, people here really kind of eye-openers, right? Or like the cardiac assessment. I think at least I work a long times with that cardiologist, but I think that was I hope at least for a lot of people an eye opener to do a bit more of cardiac baseline
risk
measures
assessment and workup. Absolutely.
And the topic we assigned you, Declan,
the glamour topic.
Digital rectal examination versus MRI. I now work at a site in Zurich that has used MRI for, I don't know, almost 10 years to define T-stage. And when I first started there, I was shocked because the guidelines clearly say you should not use MRI for T-staging. So the discussion and also what you have shown in your talk was really fascinating.
When they put this program together, I mean, we can all put together a program on prostate cancer, but there's something, everyone talks about this, there's something about the way you select topics and select speakers that's very, very edutaining, we say, educational, entertaining. And I was talking to Dana Rathkoff about that. So you often give us topics that are not in our comfort zone. We're not pulling out the favorite slides. And
Exactly.
And I really enjoy that. I really enjoy watching some of these super smart panelists you've put together, addressing a topic with their knowledge and experience in prostate cancer, but maybe not in that area, and delivering some great messages. So how do you do that? How do you, when you sit down to plan this, how do you decide those topics and assign those speakers?
So first of all, I think it was from the beginning, just also the thinking that, if you have done a trial as a lead of a trial as a PI, you're probably really biased towards that trial results, right? So we always tried to give these topics to someone else who can really neutrally from outside interpret the data also in the context of all the other trials. So that was something we to be honest, we tried to do that from the beginning. Also, a bit the effect when you go to meetings and you have the feeling you have seen these slides before and before and before. So I think, it is also something, and I guess like today, as you said, Lisa probably Harvard, it was the first time she gave that talk. She went really deep into the, the issues, and she did, the Australians are taking over APCCC, we already said that. So, but then a fantastic talk, with all the data around. I think it was really amazing.
Yeah.
But we spend a long time deciding on the program, even though we have a draft and we think it's almost finalized, and we circulate it with the scientific committee, and then a lot of things change. So a lot of work goes into the composition of the program.
And the questions, if you don't mind me asking, and you hinted at it, but at the end of each session, then you reveal the votes on these hot topics, and in the session we've just had, you revealed the votes on which AR pathway inhibitor are people choosing. So we're very interested to see, and there's some very interesting findings there. Lots of people will comment on it. But in selecting those questions out, you mentioned, Aurelius, that many Sunday afternoons and so on. It's a huge amount of work, taking 180 odd questions, and then which 4 or 5 will we use for this session 6 or whatever it will be.
So
this is very subjective. What we then select, for at APCCC, the rest will go into the manuscript.
Yeah.
But the development, I mean, we've been inspired by the breast cancer consensus, which started in 1978 in St. Gallen, where we used to work. So they have always these kind of questions, but we have gone into a different direction, I think, with making the questions, a bit more complex, also spending a lot of time on the answer options. Yes, again, weekends and again a long weekend with the scientific committee.
And the questions have to be very relevant to clinical practice, doesn't it? Because when you were reading some of them, Silke, you were saying this is a very common scenario that you would see in clinic every single day.
That are not in the guidelines.
Exactly.
That's the whole point. It's a patient with disease only on a PET scan, and he's got this comorbidity, and what would you do, So they're really, really helpful.
Yeah. And we write in guidelines, so we know, actually in the guidelines you can't add anything that hasn't been published, doesn't have strong evidence. So, but we see these patients now, and probably before we have evidence, it will take so long. So this is kind of the, let's say, for the time where we don't have the clinical trial data, I think expert opinion is the best we can get.
And I'm really interested in the manuscript. I'm sure apart from the questions, there's already been a lot of work that's gone into the manuscript. How much of it is already prepared, and how much does the discussion at the actual meeting then influence the manuscript?
Yeah, the discussion has a huge influence because we can write the background, but everything around it, also the references in the publications. We don't know all the literature, which is literally now exploding anyway. So this is really helpful. So we take a lot of time then going through the slides again, saying, we missed this reference or this point. So yes.
And every time we see a table with all the references, we're like, yes.
That's what we want. This is
Absolutely. So you can't quite relax after the meeting just yet. You've got a big job ahead of you.
Yeah, but we have some help. I have to say I have a fellow who's going to start writing or has already started writing for us a bit of the background, and also I think then we have secretaries who can put in the percentages of the answer options and so on. So and then the discussion is going to be more complicated, and what maybe takes a really long time is then we get comments from 120 people. so Aurelius is super because then he's sometimes creating that document with all the comments and it's hard to read.
I agree. This is always the part I like the least, even though the comments are very valuable. But we still haven't found a way of working a manuscript with so many authors at the same time. It's still then sending out versions and compiling them. So,
and then finally, you're going to be back at this main meeting in 2 years' time. We can see it's 29th of April to the 2nd of May, 2026, back here in
Fortunately,
beautiful
the location
Lugano.
doesn't change because it should never change.
Unless you need to move to a bigger conference centre. But no. But you've also a new meeting starting next year in between the main meeting, which only happens every 2 years. So.
Exactly. So Ken Herrmann and Stefano Fanti approached me with that question if maybe they could do something more about imaging, and then we discussed and we said, that would be great because the APC can, because we couldn't do the work every year. So then but then we have something every year. What is nice? It's an important questions. We can then also take these questions out of the main consensus, and so they can really ask more the imaging, but also the molecular pathology and so on questions, like AI now coming and everything, right? So this will be all in that meeting, and I think it's a really win-win, So we said yes, let's try it, and I hope a lot of people are coming because I think it's an important topic as well, right?
I totally agree. It
and the best questions from the diagnostics will then make it into the 26.
Because it is such a key part of it.
Ahead. Absolutely, let them do the work.
We even now have already made some questions, and we said, you know what, we have so many questions because we wanted to go back to 120, still ended up with 180. So we said, okay, some of the questions we can really directly give to Stefano and Ken, so they can then use them in their meetings. So I think it will be a nice collaboration.
It will be great.
Well, you guys are amazing for getting so many incredible people under one roof at the same time. That's an incredible feat.
It is. So put it in your diary. Quite a few Australians even travelled all the way here. Quite a lot of trainees, senior fellows. It's a great meeting.
Thanks to you both as well.
No problem.
Thank you.
Congratulations.
Congratulations.
Thank you very much. We're joined by Dr. Yüksel Ürün. So nice to meet you in person, Yüksel. How are you?
Fine, thank you. Hi,
You're a Twitter legend.
Thank you. Actually, it's a pleasure to be here with GUcast, which is really rising in the city, and I'm happy to follow your Twitter and podcast and all things. It's really a pleasure to be here for me.
Well, that's good to hear, because if you're interested in geo-oncology, which you must be listening to this podcast, and you don't already follow Yüksel Ürün, well, you certainly should. I've followed you for years and years, and you've just become an incredible resource for keeping up to date with stuff happening in geo-oncology. I don't know how you do it. I mean, you go to a lot of meetings, but you're very busy at the meetings. Your tweets are amazing, structured tweets summarizing everything. I literally save everything off, or if I miss a meeting, or if I'm in the operating room all day, I come home and I'll just look at your Twitter feed and I make notes. So that's why we wanted to get you on the podcast to talk a little bit about, why you do all that and where you think, the future of Twitter is for that sort of dissemination.
Actually, as you saw, I'm a medical oncologist and do GU in Turkey at Ankara. Most of the colleagues, like you ask me why you do in Twitter and other social media. Actually, there is several reasons behind this. One, it's make it easy for me to stay focused during the meeting, and also I use this all tweet and all other things like for my personal library. Even for me, it's easy when after the meeting, if I want to look something, I go back and find easily.
There's the hazard ratio and the
of course. There is one, and the other, even before Twitter and WhatsApp. Anything is important for me, I distribute it by email 10, 15 years ago to my colleagues. Actually, because why? I believe global health and sharing knowledge, it's one of the best way to improve the average for global health. Because this is the why we are here. We are all here to find the best solution for question of our patients to improve their life. But I think one of the first steps for this is to improve knowledge of our colleague. And of course, this is not only for colleagues, also several patients follow us on social media and increase awareness. I think this is the best way to do for all, because if we improve average knowledge, if we improve our patient knowledge, our provider knowledge, it will help to do best for our health system globally, I think.
Very good.
I think he has a very similar philosophy to us, which is that dissemination of important information is so important. And that's something you do very well.
It's not easy for all physicians, especially for people from low middle income country, to be able to come to the meetings, and even some journal paywall, and it's not easy for all people to be able to reach to this knowledge, to this information. So I think the people who are here, it's one of the actually things we should think about it, and which we should all to make any contribution. I think any contribution for this issue is count. And it's not any time. I don't think it's a waste of time, because I get so many really excellent feedback from my colleagues, and even the people I never see before come to me. They say, "Okay, I follow you. I get very well information from your tweet, and actually it's make me happy, and it motivates me for continuing this."
Yeah, it's very impressive, and it's not just meetings. When there's a new paper released, he's right on it, and he sends a tweet with the pertinent things. So how do you keep your finger on the pulse like that?
Actually, as a geo-oncologist, I have to follow them and keep it update. And for me, it's like it's one of the egg, because whenever you share before you make a post, you need to concentrate the data, you need to focus and make a comment for yourself. This is the final take-home message which I share on X or Twitter.
I love
Very
it.
good.
And also, unlike just a conventional news site, you don't just pump out the data. You always put a bit of clinical interpretation
Yes,
on
of course,
it.
of course.
Is that part of your philosophy? I mean,
yes,
there are other ways in
because-
which you can find. Here's a
because
summary,
because there is information all around, and it's something about me. I try to put my interpretation because most of the people, especially young generation, residents, fellow, they want to learn why key opinion leaders do in their life, what they understand from this data. And I try to put also my understanding about the data.
Yeah, I love it.
It's very impressive.
Now,
I think
and still, Twitter is your main tool, would you say?
Actually, still Twitter or X is one of the main, but I think since also we work in some project, we all know that the attention span is very short,
getting
for
shorter.
especially and getting shorter for young generation. So I think in the future maybe people will less read. So doing podcasts like that, visual thing, visual audio, it will get more attention. I think also I need to work on this, and maybe I can learn from you about this to do it.
that was going to be my next question. Are you planning on starting a podcast? It looks like you might be.
I learn from you.
Well, it's interesting how I think podcasting, which is a long-form way of discussion, has a clear role. It's become very popular, and people are cycling into work or out for a run or preparing a meal, and you're listening to a podcast. It's a longer form. But what you've just mentioned is like the opposite of that. It's like you want a 30-second gratification of a quick short-form video on TikTok or Instagram Reels. So both of these ways of communication need to exist. And Twitter is like, it's still the example of short and snappy.
Actually, I am not happy with Twitter. They increase the amount of word you can use.
Yeah.
I like 280.
I thought 280 was perfect.
Yes. I like because you should be more concise and simple.
Yeah.
And just one example. Actually, these modern things, this digitalization change even our way of doing music. I know you all are fan of the music, and in the past we have a very long intro.
Yeah,
but
1
now
or 2 minutes.
in the first 1 or 2 seconds they start to singing.
Yeah.
And this is all because of the attention.
And because if somebody's listening, I think on Spotify, we were talking about this, right?
Of course.
I think it has to reach 30 seconds
Yes,
before the artist gets paid.
Yeah.
But if it's a bit boring, a bit of a long, and then they flip on to the next song at 15 seconds, well, Dua Lipa is not going to get paid. So therefore, the first 30 seconds has got the chorus.
We all have to be very
so we have to be the same. We have to be the same.
We have to be very concise, very short, direct message. And of course with some personal comment.
Yeah. So you might have a direct message, for example, about Pembro for adjuvant. Hakim would say, practice changing overall swab, and then here comes the data. So I've seen you in your style. You'll often do that.
Something to grab the attention, and then the data.
Well, there you go. It's a great job you do. It's lovely to meet you in person. As a surgeon following you, I think you make the GU medical oncology. You make it very simple.
To know, and actually, it's also make me to be able to continue because it's a big motivation. If you know, it is really helpful for somebody.
Absolutely.
And remind me of we'll put your Twitter thread in the notes and on Twitter, but how do people find you? Your Twitter handle?
My Twitter handle is DRY UKSELURUN.
Dr. Yüksel Ürün. We'll put a link in the notes.
Keep doing what you're doing. It's amazing.
It's easy. Congratulations. Keep up the good work.
Thank you. Thank you for having me.
Well, we're joined by the Chief of OncoAlert, Dr. Gill Morgan. Gill, how are you? Thanks for joining us.
Just great fine. To see you, Gill.
Yeah.
Thank you very much. Thank you very much. A pleasure to be here.
Well, it's great to be here.
In the flesh,
we all know him,
we know your reputation, but this is incredible to see you in the flesh. And OncoAlert, amazing job that they've done.
This is the first time OncoAlert have been here at APCCC?
Yeah, this is the first time, so we're very, very glad and very honored to be part of this meeting, because quite honestly, nothing could have prepared us to what it actually is like to be here in real life.
Yeah. It sure is. So I'm sure very many of our audience who are interested in GU oncology might be following OncoAlert, but many might not. So can you tell us a bit about, we're big fans, and it's a huge endeavor, but can you tell us a bit about OncoAlert and how it it came to be and what it does.
Absolutely. Well, I mean, like with everything, it's OncoAlert has been a labor of love. So I think all of us that are actually a part of OncoAlert, including the faculty, do this because we really believe in it. We believe in the value of oncology education and making sure that whatever is coming out, that everybody has access to it. And I think that's the most important part. Myself, I'm a clinical oncologist by training, so I kind of dabble a little bit on every tumor group. So that allows me to deal with the day-to-day, because that's what we try to do. On a weekly basis, we try to make sure that we're covering all the top trials, all the top news, but when it comes down to specialized meetings like this one, we're very happy that we have a great faculty, especially our GU faculty, who just steps up, and really they're very supportive. So we cover meetings like this, and why do we do it? Well, we do it for our colleagues that can't really make it to the meeting, the ones that maybe he or she is a junior faculty, and maybe it's not the time for them to travel. Maybe he or she has some financial hurdle. Maybe it's maybe they don't want to contribute to maybe the green gases
the environmental impact. Absolutely.
That's what I was trying to get to.
It's a very valid point.
Yeah.
Yes.
So this is a way of getting the information straight to them to make sure that no matter what is being discussed, they're up to date to the second. And this is why we have that slogan that, no matter geography, we're all OncoAlert. That's because we really want to be the eyes and the ears of all of our colleagues and make sure that if we're there, they're there, and they're getting the same information as everybody here.
So OncoAlert sounds massive. How many people are in the faculty?
The faculty is right about 160.
Wow.
And in all tumor groups. Quite honestly, the most amazing thing about the faculty is that the faculty is also made up of 10% patient advocates.
Right.
So we always have the patient advocate voice in there. So we have 3 mandates. That's the beauty of it, is we're all very, very like-minded. Number 1 is the amplification of oncology education. Number 2 is to make sure that we amplify the voice and the need of the patient advocate. And number 3 is to create equity in oncology education, especially in LMICs.
And what are your forums of dissemination?
Well, we started off on social media, and of course we're still very much there. We're just kind of broadening up to LinkedIn and the other platforms. But we also have our newsletter, we have webinars, we have the podcast. So there's very little that we don't do, and we take inspiration from you all, because what you're doing is just fantastic. And it's just such a great forum for people to learn, to dive deeper. So we just want to make sure that we are doing the same thing that GUcast is doing, and that we're giving that kind of education to the other tumor groups.
It's the edutainment.
Edutainment.
Exactly.
But I have to marvel at your efficiency, and because you're not just doing GU, but you're banging out these messages and summaries so quickly. Even watching you here at this meeting, you've been sitting behind me, laptop going, and you've got a colleague, I think, here as well, and you've got some ambassadors. But wow, it's like relentless. I know how much work that is, but you've been doing it for years. You're doing it all the time. How do you do that?
But here's the beauty of it, because thankfully last year we launched as an official NGO. So it is. It's a nonprofit charity, and we started off at ASCO, and they were the first ones to recognize us as press and media. So as press and media, we were able to go in there, and I remember I was very. When you walk in there as a lone oncologist into a room full of media, and you're like, oh, what am I doing here? And then I don't have a team, it's just me. But then I remember my team is out there. My team is in the auditorium taking pictures and making sure, because all of my colleagues, that's my team. And the faculty, they're the ones giving the presentations. So when you have that kind of backup, this is easy. So like what I do, it's just something that has to be done. I'll work in the computer, but really the real superstars is the faculty and all the people that actually support all our colleagues that are OncoAlerting in real time. And that's the beauty of it. I think after the first year, I heard that OncoAlerting was actually a verb. And that's how you know you made it.
Just like GUcast testing.
Exactly.
Onco
We're
alerting.
going to start using that one.
And you've been very kind. So we have we gave out some travel awards to bring some trainees here, and you kindly invited them into your sort of ambassador group, and they dialed in, I think, to a Zoom webinar where you were just sharing tips on all this. So I love the fact you're building this huge community, and I suppose it does help you with a critical mass of people to grab content and stuff.
Absolutely, but that's where it works. I mean, we're all friends, or we all should be friends, and we all should be helping each other. And of course, we're all doing it for the same cause. So there is no reason that we shouldn't be doing this. So we hope to be able to be collaborating and doing more things, not only with GUCast, but a lot of other people out there.
And just to get an idea of how big all of this is, I mean, when you come to meetings, it's relatively more straightforward to get the data because you're right there. But what happens from meeting to meeting is another kettle of fish altogether. So do you collaborate with journals? How is it that you know exactly what's out there every minute of every day?
We do, and we do have partner journals. So we are partners with all the journals from the American Cancer Society, and we have other journals that we collaborate. Those were the ones that were the biggest collaborators, and that helps. But quite honestly, nowadays, with all the tools that you have, I mean, there's apps out there that'll give you straight articles as they're coming out. So it's very easy to keep up to date if you want to. So what we try to do, we just try to simplify it. If somebody does not have the time and doesn't have the know-how to do that, I'll do it for them, and I'll put it out there. The same thing for the newsletter. The newsletter covers the top 10 articles of the week every single week, every Thursday at 3:45, and there I am curating it. But I can simplify it. I'll give a link to the actual article, I'll do a synopsis, and then I'll give you a take home. And everybody could read 10 articles in less than 2 minutes. And that's what I want, so that anybody, so there is no excuse. There's no, well, I can't do it. Here are the top here's 2 minutes. Give me 2 minutes of your time. I'll catch you up to speed. Wow. So hopefully we're keeping true to that.
I think we need to work a bit harder. I'm feeling like we're a pair of slackers.
Absolutely not. Absolutely not.
Incredible work.
Keep up the onco alerting, and it's great to meet you here and learn from you. And we're all in the same mission.
And if anyone's not on board, Onco Alert is the place to be. It's like having your dinner served.
And it's easy to find wherever you get your content. Just search Onco Alert and follow Gill and his team. His community. Join his community.
Absolutely. Yeah. We do hope to be able to work more with GUCast here in the future.
Yeah, let's do that. Good to see you.
A pleasure.
That's it for our conference highlights from this year's APCCC meeting. Congrats again to Silke and Aurelius and the scientific committee who put together this quite outstanding meeting. It really is our favourite prostate cancer meeting, and we can't wait for the next one to come around in 2 years' time. However, there is another APCCC meeting, a new meeting focusing specifically on diagnostics in prostate cancer, which will be happening here in Lugano next year. Search APCCC Lugano for more details. Thanks again to our gold partners, Bayer China, for helping us bring you these conference highlights. We'll be back again very soon.